Okay, we're going to move to the panel Q&A session now, and I'll take questions. I'll repeat them just because we're recording this. We want to get the audio on those, and then we'll let our panelists respond. So looks like we've got a question in the back.
Thank you.
Let me just repeat that, if you don't mind. He asked about the percentage of the population that is a potential user of cannabis treatment.
That's a great question, and the answer to that is a little fuzzy. So I'm going to give you a nice fuzzy answer. It depends on what conditions you're talking about. If it's just Dravet syndrome, not very many. I mean, it's a pretty severe condition. There's a few kids who have it. If you widen that to epilepsy, I don't have percentages for you, so I'm just trying to kind of give you an idea of what we're looking at. If you widen that to epilepsy, obviously that increases it. And I have met adults who have seizures, and they say the only thing that stops them is the CBD, all right? If you broaden it to PTSD, well, now you've got a whole range of veterans that come into the picture. You broaden it again to chronic pain, well, once you go chronic pain, then that brings in, as you can imagine, a large percent of the population. Now, so this is why we have to be careful. If we're talking about this many people, we better make sure that it's right. And before we go saying this stuff works for chronic pain, we better know, does it work for everybody? How well does it work? Does it cause addiction? Are there other side effects? Those are the kinds of things doctors don't really know right now. We know for some people it works really well. So I don't have a number for you, but hopefully that gives you some idea of the scope, depending on what conditions you're looking at.
Other questions? Randy.
For Representative Ward, in regard to the opioid, say a physician only subscribed, 5 days, worth of this narcotic. The physician checks back 5 days later to determine how the patient's doing. How can the doctor determine if the patient is telling the truth when he says, "Oh, doctor, I'm in a lot of pain. I need some more of this"? And the second question is with so much social media going on out there, are the physicians concerned that patient might go back and write a bad review on this doctor for not giving him another 2 weeks worth of that narcotic?
Let me just repeat that question. It was a long one, so I'll do my best. Yeah. It was actually two, but I think the first one is that the scenario was the physician prescribes 5 days of an opioid, and at the end of the 5 days, the recipient reports that they need more. And how do you know they're being honest and accurate with that? And I've already forgotten the second half of that. So.
Negative reviews on social media.
Oh, and then if that happens, how do you deal with negative reviews on social media if there are people that don't like the fact that you are not willing to overprescribe in their opinion, or underprescribe? So
part of the many reasons why we got into this mess, one of those reasons was, I think, the federal standards that said pain is the fifth vital sign, and doctors will be judged on whether or not they leave patients in pain, and that became very important. And while that is, I'm not saying that isn't important. That is still important. It is just also important to acknowledge how addicting the medicines are and to balance that out when you write the prescriptions. And public perception is changing. I think more and more people are coming to understand the dangers of the medicines together with the pain relief benefits. You're always going to get one bad review here or there, but in my personal experience, patients are very grateful when you talk about both sides of the coin before you write a prescription for them. When you say, well, I'm going to write you this 5-day prescription, I really think that's going to be plenty for you. You may still have some pain. I won't leave you in a lurch. I'll still help you out. But believe me, you really don't want to be on this for 2 weeks because of the risk it might be to you. People say, yeah, you're right. I don't. And then you work with them. For myself, I'm not afraid of that bad review just for that. I figure if I talk with patients, it's going to come out okay. And the second question of how can you know if the patient's really in pain or not in pain, or if they're just gaming you, the short answer is you can't know that for sure, but we have way more tools than we used to. The controlled substance database is right there, and you can and ought to, as a physician, be using that particularly if it's a first prescription, to see if there's a pattern. And people sometimes think, oh, you're just looking for the ones who are gaming the system. I'm not just looking for the ones who are gaming the system. I'm looking for that too, but I'm looking for the patient who's had 3 narcotic prescriptions in the last 4 months, all for completely legitimate reasons. They had their tooth out and it took 2, they had a sore throat and they got a cough syrup. So that before I write that prescription, I can say to the patient, I'm not saying you're cheating the system, but I see you've already had 3. I'm about to write you the 4th one. This could be the one that your brain latches on and you never get back off. Are you sure we want to do that? Let me try with high-dose ibuprofen for you first and see how that does. And patients are grateful for that conversation. You're not going to be perfect every time, but you're going to be way more likely to be accurate than if you don't do that.
And I think the back end of that question was, and I don't know if is there a Yelp for doctors, or but social media and being reviewed on that unfavorably, is that something you're having to manage, and if so, how? And I guess for both Dr. Ward and Barlow, is that something that is becoming a concern at all for you?
Well, I'll take that question first. For me, I don't look at it. So no, it's not an issue. It really isn't. The second thing is on the prescription. I think a lot of things have happened. In fact, we're now seeing that curve really starting to bend. It's come down, a good 7% just over the past year or two. And I think part of that, and that doesn't mean we're at where we need to be. There's still a lot that needs to be done. I agree with Representative Ward on that topic. But physicians are changing. And if you haven't, I bet any of you been into your physician and you had an operation or you needed pain medication, and you've had an operation in the past, were you treated the same as in the past? Did the doctor give you a ton of pain pills? I think most physicians got the message, got it loud and clear. And not only that, we take every 2 years, we take 4.5 hours of basically narcotic education to reinforce it. It comes as mandatory from the state. And I think the physicians are all very serious about this. Now, you may have some areas where you have a pain clinic and you have a volume of patients that are on a lot of pain medication, but aside from that, the physicians I know, and most of them are surgeons that I deal with, you really kind of watch what you give out. That's why I like the partial fill. That kind of fits into Representative Ward's bill too, but where we could just, you have a set amount that they can get, just like they did before. But you can always reduce that, which most of us already have reduced. And you can say, here, instead of picking up the whole prescription, just pick up a couple of days. Just see if you need it. And if you don't need it, you're done. And if you do need more, then you still got the other part of your prescription. You don't have to call the doctor. You don't have to jump through hoops to get a prescription. You just go back and get what you want left on the others. And so you could take a couple more days if you want, or you can get the whole thing. Well, the hurdle for patients is having to go back and see the doctor. That's the hurdle. And those patients, the doctor hop, we catch them because they're on the database. And so, you know what, the system has kind of revolved and it's kind of changing. Are we where we need to be? Probably not, but we're on the track. It's going the right direction. And I don't think anyone's too worried about your social media image being dinged a bit. At least the people I talk to.
If you want a certain kind of review online that will take place very reliably and very quickly, give however much narcotic to whoever comes in, how much they want. You'll find a very grateful and willing clientele that will show up in short order if you get a reputation for that on it. And in our clinic, we really don't worry about it. Not because it isn't important, but honestly, I don't even think you can. There isn't just one place that you get reviewed online. There are 1,000. And for every 1 or 2 that I see, if I choose to worry about that, there's another 500 that I didn't see. I could worry about those too if I saw them. If we just do the same things we've always done of treat our patients well, it'll work out.
Right. Let me ask a follow-up related question to that, and that is, we've got this audience of 100+ health information technology people. As you think about the technology tools that you have at your disposal now to manage opioid abuse or misuse, or even cannabis, any low-hanging fruit any of you see in terms of substance databases that you access, electronic health records that your systems you're using, anything that you look at and say, boy, if we just could make this one or two small changes, we could really enhance our practitioners' ability to do this better. So anybody have
Well, it's
ideas
not
on that?
low-hanging fruit, but I'll tell you what would make a big difference, and that was if you didn't have to log into the controlled substance database separately. If we got to the point, because even that step, you say, well, it only takes 30 seconds or 1 minute to log in. Yeah, but I only got 10 minutes with the patient total, and that you just took 10% of the time to log in. And that's not easy, but if we got to where that information was internal to the system that the physician was already using, it'd make a huge difference in how willing and reliable people were about using it.
Any other thoughts on that topic?
Well, I think Dr. Ward said it just exactly right. There is no low-hanging fruit. We have been at this for a while, and we've plucked all that off. So we're climbing up the branches now. I will say this, we try to address these as best we can. You're right, the database login procedure is a bit onerous. I mean, my ideal would be that when you pull up their electronic health record, that it's just right there with it, that everything is right there all in one spot. You don't have to go, but absent that, if you are a doctor, you can designate somebody to do the lookup for you, so you can get a printout of it or just have it right there in front of you when you go to see the patient. So we're doing our best, but yeah, there's still a lot that needs to be done.
I think public education is vital, and it's going on now. One of the hospitals up north, you walk in the hospital and there's big things on the floor, You have options besides narcotics. You get in the elevator, there's another plaster, Did you ask about other options instead of narcotic pain medication with your doctor? And so forth. And you know what? People are getting it, I think. They, at least in the area that I treat as a surgeon, I have people now who say, I don't want a narcotic, give me something else. That never happened in the past. And they realized, they made the connection to deaths and the use of narcotics. And I think education is really the key.
Can I answer your question? You ask about low-hanging fruit and what's important in health information systems. I would like to change the topic just a little bit and just say what I think is the single most important thing in health information systems. To me, this is more important than all of the other quality things that we talk about. And that is, and we're not there, we're nowhere close to there, and that is to get to where the provider that is trying to make a medical decision for the patient can, during the visit, when they're visiting with the patient, access the health information of what has already been done for that patient. That basic thing of being able to see what has already taken place, we're not anywhere close to that. If it's in my own system, it's all there. It's great. It's all there. I can see it. But if it's not in my system, it is a hodgepodge of misery. I've got 4 different logins at my clinic. They go down at different times for different reasons. Even when I log into the various systems, it's hit and miss about what's in there. The controlled substance database has been down for a month. They say they've just about got it fixed. They're about to have it fixed. The vaccine database, the state vaccine database. I had a patient this morning who I still am going off the patient verbal report as to what they've have had done. The lady tells me, oh, I've had for sure one of those pneumonia vaccines. I believe her. I'm guessing it's the Pneumovax. I hope it is because I'm going to give her a Prevnar. And she got a shingles shot at a different place. But the pneumonia vaccine and the pneumonia and the shingles are not in the state database. So I'm just going to guess which one she needs and give it to her. I may have duplicated it or not. No one's ever going to know. When I log on to the CHI, there is some information there that is very helpful. There are still large swaths of basic information that's not there. I almost had my head pop off this morning. There's a patient that I badly needed to call a result back to a mother about her daughter's x-ray. I log on, I can see in the chi that it's been done. The result exists, result isn't there. What has been successfully loaded is notification that the procedure has been done. That's what's there to me. But the basic report does not exist there. And this is my day all day, every day with these kinds of things. So to get, I don't care about any other quality project, I hate to say, but if the information of what's already done is where the providers can get it, we'd be so far ahead.
There's a challenge for all of us. Question, Kim.
Well, just related to your point, you're not going to be able to see my medical past until I have a patient identifier that everybody recognizes, and you can consolidate all of my information of me in one place. So it's not going to happen until that.
So I think the comment was on a common patient identifier, which is probably as much a public policy issue as it is a technology. In fact, it's probably more a public policy issue than a technology issue, right?
Talk to me after.
I can address that just very briefly. I mean, obviously, there's a huge concern. I mean, above and beyond HIPAA, there's a certain segment of people out there who are absolutely terrified to have their information on a government website. I did say government, so you have to overcome that, and you have to have assurances that that data is protected from those who would, because frankly, your medical records contain some incredibly sensitive information. So you do have to be careful with that, and that is one of the real concerns that has always been expressed anytime we start going down this road. We are progressing, but it is at government slow speed, which is, you know, you have to tie a string to it, go away, look, come back every once in a while and see if the string's getting any tighter. That's how you tell if it's moving ahead. So.
The only way that we got social security numbers was because it was before there were computers, right? So
Yeah.
nobody ever thought that number would be violating their privacy, you know.
And what's ironic about that is if you look at your social security card, it is not to be used for ID. Ha 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 ha. Sorry.
Okay, I think we've got time for one more question. So, Jesse?
So real quick, a couple disclaimers. I was an average poli-sci student. And I recognize this may be out of your domain, so I apologize if the question is irrelevant. But going back to the opioid crisis, you know, with the potential elimination of the Office of the National Drug Policy that we hear about in the news at the federal level, how could that potentially help, hinder, support, or hurt our local efforts? Or does it? Is there any correlation about that?
So the question is, does the dissolution of the National Drug Policy Office help, hinder efforts here locally in terms of managing some of these issues?
Do either of you recall that that's been helpful to us so far?
We had a visit from the director of a gentleman who became the director of ONDCP. Now, the one thing they did do, which I have very mixed feelings about, was in connection with CMS, they did start a medication-based treatment program for opioid abuse. In other words, they're saying that the way to get off of this is with Suboxone and other kinds of medication like that. I'm not convinced that was the world's best move, but that was the direction they went. So no, I think we've always kind of been on our own, and I think, frankly, we're not seeing much traction, and we're still on our own. We're dealing with it.
In the end, the problem won't be solved. I shouldn't just be sarcastic about it, but I honestly don't know what they've done to change the situation. The problem will be solved when the medical community of people writing prescriptions and the public as a whole comes to regard narcotics as useful but very dangerous, and that you need to be careful with them.
One more question, or do we need a wrap? I think we have time for one more question, so in the back.
So we talked about disruptive innovation, and challenge obviously in government is speed with some of this stuff. Are you guys aware of anything actively going on to where the doctors actually get reimbursed for helping the patient's getting what they need in a more timely way, but yet the reimbursement policies favor fax machines and in-person visits.
So the question was, if I can try to paraphrase that, are you seeing new innovations that allow for more, I think, real-time use of technology that accelerates both care as well as reimbursement for that care? Yeah.
I'll take a quick stab at it. I talked a little bit about telehealth medicine, and this past year is the first time that we've been able to tie reimbursement to telehealth. Before it was available, but it was not existent. But I think all of us are just seeing this area just balloon. Now you just take a picture of the problem and you send it to your doctor. Most of us, I think, like that. It's a good way to get back to interacting with your patients. Do you get paid for it? No. But actually, I'll take it back. Some of the insurers do pay some groups, so that's to do a quick chat with a doc online. So yeah, some are getting reimbursed, but I think that's the direction of medicine. I see that being a very important step.
Let me ask you all a question. How many of you know why, I don't know if we still do, but it's been very recently we haven't. How many of you know why up until at least recently we have dialysis centers? Anybody know that? As I understand it anyway, the reason we had it is because the law was passed back when dialysis machines were as big as washing machines, saying that everybody with kidney failure has a right to dialysis. And of course, in the law, they were brilliant enough to put in the law what the dialysis machine looked like. And so even though dialysis machines have over time vastly improved where you can give it to yourself during the night, you still have these dialysis centers for a long time. The reason I bring that up is the very best way to have disruptive innovation is to get the government out of the way. I mean, really just get them out of the way. And I'm saying that as a legislator. Now, what we can do there are things that we need to do there. If we had, in my opinion, if we had patients with more skin in the game using their own cash through a health savings account or some other mechanism, then what in the world is to stop them from setting up some sort of private agreement with their doctor saying, hey, listen, can I just call you now and then? Can I text you? Bill me however feels right for that billing. And we're just paying cash here, so you don't have to involve the insurance companies, you don't have to involve the government. Medicare, Medicaid, it's just me and my doctor. I mean, what's wrong with that? I think the answer is nothing. So the best thing we can do, what I'd like to see happen both locally and nationally, is people being able to, except for the really catastrophic things, of course, people being able to spend their own money to purchase the health care services and products that work best for them. That's what I want to see.
Okay, and I think with that, we're out of time again. I want to thank all three of these fine legislators. Again, here in Utah, our legislators they have real day jobs, and they do this on their own time, and they're coming here on their own time. So I really appreciate all of you joining us today. Thank you.